There you go.
Okay, thanks, Jane. So a very warm welcome to all of you on what appears to be the first of what I might term the really dreary wintry evenings that are no doubt going to come over the next couple of months. But we're certainly embarking on this journey with a positive outlook. And so a very warm welcome to everyone from St Albans and District Soroptimists. I'm Barbara Saunders and I facilitate our people team, and we operate our club with three teams, one which is concerned about the environment, one which is concerned with violence against women, and the people team which considers health, education and matters from the justice system. So we have a fairly busy and active programme, and women's health is one of our special interests. So it's really good to see you here this evening. And for those who are joining us for the first time, I hope you enjoy the event and look forward to seeing you at some of the other events we organise during the course of the year. I'll give Professor McNally, Scarlett, a proper introduction in a few moments, but suffice it to say at this point that, Scarlett, we're really, really grateful to you for taking the time out from what is an incredibly busy schedule, I know, to share your knowledge and your experience with us, and we appreciate that very much indeed. I'd now like to ask Debbie to just read our vision and mission. You're on mute, Debbie.
Is that better? Can you hear me?
It certainly is.
Sorry about that. Okay. Women and girls will achieve their individual and collective potential, realise aspirations, and have an equal voice in creating strong, peaceful communities. And our mission, Soroptimists transform the lives and status of women and girls through education, empowerment, and enabling opportunities. Okay.
Thank you. And now to the main event. I don't really know where to start, but Professor Scarlett McNally is an eminent woman with a formidable CV. I should think those of you who've read any of her publications or indeed her CV itself will have been as impressed as I was. And Scarlett, you've managed to combine a career as an orthopaedic surgeon with representing women at the highest level in your profession. And as if that wasn't enough, you now seek to improve the health outcomes for society in general and for the health service, leading by example and sharing your experience and knowledge. We very much look forward to hearing about your journey and some of what you've learned along the way about women, health, exercise, and the economy, and how we too can add our voice to help try and change the narrative about health outcomes and the future that's in our hands. Over to you.
Thank you very much for that introduction. I'm just going to share my screen. And hopefully, there we go. Is that showing all right? Yeah. Lovely. Yeah. Well, it's very nice to be here, and thank you for the introduction and the invitation. I'm quite tired. I think I'm still on summertime. And I was operating this morning and had a clinic this afternoon. So do wave at me if I'm going off on a tangent. And I have far too many slides because some people are visual, not really learners, but taking information that way. And some people prefer reading or being spoken to or something. And it's got lots of hyperlinks if you want the slides later. So I've been an orthopedic surgeon for about 25 years, and I do some other things. I'm just going to say this recording will be available later, but if slides aren't your thing, you can look at the podcast of a thorough examination with the Van Tulican twins. And I've been on various things. If you get the slides later, you can find. Just to say, I have no conflicts of interest. My only income is from East Sussex Healthcare NHS Trust, where I'm now part-time as an NHS surgeon. The Royal College of Anaesthetists at the Centre for Perioperative Care pay for half a day a week of my time as a deputy director. So that's sorting out the care of people having surgery, all the stuff around it, not the actual operation. And I'm a columnist in the BMJ, and I donate the money from that to the Medical Women's Federation, where I am currently president, which has been very interesting. I've done some other things in the past for free, essentially for fun, voluntary stuff, and I'm involved with some of that in going forward. So this is me, really. I deliberately use a picture of me from 21 years ago. That's me operating when I was pregnant. That kid's now at uni. Just do that to subliminally tell people that you need to get women through certain phases of life in order to maintain them in the workforce. I was on the Council of the Royal College of Surgeons of England for 10 years. That's me with a tree growing out of my head, which makes me into a Greek goddess, I believe. But that's my diversity slide. It's now got many more women and many more people of colour on there, and that's about setting standards for surgery across England and Wales. And I have a column, as I said, in the BMJ, and in fact you can get that. It's open access every fortnight. You just put in BMJ Scarlett McNally of whatever you want to look at, and it will come up with different things I've done. So this is the day job. That's a dislocation of a finger joint. They're quite common and quite straightforward usually to reduce, always a bit swollen afterwards. So interaction, what's the most dangerous activity you can do? Anybody? Give me a shout.
Walk down the street or drive a car.
Thank you. So those are both more dangerous than they should be, sadly. But actually, it's sitting down. It's what we're all doing. And most ill health is caused by social deprivation, a sedentary lifestyle, or smoking. And genetics is only responsible for 20% of ill health. And bad luck, lots of people suffer with, and that's you can't really necessarily change. The biggest predictor of ill health is social deprivation. So this is a chart from the Marmot Review in 2010, but sadly it's probably got a little bit worse. So there's, if you break up the population areas into the least deprived and most deprived, break them up into 20 groups, those in the most deprived are 2.5 times more likely to get heart disease, which is the light green, or cancer, which is the dark green, per race of the population than in the least deprived. And that's just not fair. And you can see it's a dose dependent curve. So it's a real effect. It's not just some random aberration. This affects millions of people and causes ill health. This is another way of looking at it from a report quoting the Marmot curve. So if you think this is the average year of death per neighbourhood income deprivation, and that's the top line. And so if you live somewhere posh, you live 9 years longer. But the bottom line is when you start getting ill health or medical conditions, and you can see that starts much earlier. It starts another 10 years earlier. So if you could get the people in the least deprived area, in the most deprived area, to have the same fitness level as the people in the least deprived area, you would reduce disability, sickness, and costs to the NHS and to the taxpayer. So that's basically what I'm going to talk about for a bit. So, kind of what causes ill health, and we can talk about parenting, social deprivation, education, pollution, accidents, as in things that shouldn't happen. And these are all things that we absolutely need to work on, and they're incredibly important. But on the body level, how does it actually work? How do those things cause ill health? And it turns out they work through nutrition, smoking, physical inactivity, and pollution. That those are the main things that cause people to become ill through their environment. So I was lead author for this report in 2015 called Exercise, the Miracle Cure. And it's from the Academy of Medical Royal Colleges. So there's one representative from each of the Royal Colleges. So there's an anaesthetist, an obstetrician, a paediatrician kind of thing. And basically on the Health Inequalities Forum, we worked out that we were measuring lots of this inequality in health, but what were we doing about it rather than measuring it and advocating for people? And so I suggested, and I was lead author for this, that we collected over 200 references about how exercise can improve your health. And so these are some of the numbers from that report, that exercise at a dose of 150 minutes a week reduces your risk of dementia by 30%, stroke 30%, bowel cancer 40%, type 2 diabetes 30 to 80%. All of these things, it reduces your risk of ever getting. And that, as I say, it's a dose of 150 minutes a week. That's about 21 minutes a day. Does it treat those conditions? Yes, it does. So it reduces the risk of falls by about 50%. But if you've had a fall, it builds up your muscle, so you're less likely to have another one. Or if you do, you're less likely to break something. And on the right-hand column now is the UK lifetime risk. Are these common conditions? Absolutely, yes, they are. And this is from the Lancet Global Burden of Disease for UK, disability adjusted life years. So these are the causes of disability, having extra years living with disability or ill health. And you can see physical inactivity or low physical activity is right up there in the top 5. And there are other things you go further down, diet low in vegetables and diet low in whole grains and things like that. Just and smoking's right at the top. And then all these kind of conditions get more common with age. So I've put the line there where you're 65, because everyone can think of someone who's 65. And at the age of 65, 50% of the UK population has multiple comorbidities, multiple, 2 or more of these long-term conditions. But lots of people don't. And it's very variable. And it ought to be a 3D curve because there's that social deprivation element as well. But if we could just get people to have 1 or 2 fewer conditions, or the impact of those conditions to be a bit less, then we wouldn't need so much healthcare. So exercise is a really good way of improving health. So this is just kind of the practicalities. There are different types of exercise. There's fitness, which I'm going to talk about most. That's the cardiovascular fitness, 150 minutes a week of getting a bit out of breath. There's strength, and that's really good for building up your thigh muscles so you can get out of bed if you're in hospital, and then you get home more easily. So if you fall, you don't break things, break bones, I mean, and balance. And then if you're coming up for an operation, you need to do lung exercises and something specific for your operation, perhaps, say hip replacement or something, you do specific exercise. This is just an aside. There's me, that's my arm. I've got the most beautiful veins. They don't show up in the light here, but they're beautiful, aren't they? Absolutely stunning. Don't you just wonder, any of you medics on the call, put a drip in there. I've been going to the Macmillan Centre a bit too frequently, really, for the last 6 years. It's lovely and I'm doing well. But there's loads of people that have to get long lines, that people struggle to get their veins. And actually, I think what we should do when someone gets diagnosed with cancer is give them weights It gives them something to do. You just build up your muscles. When you build up your muscles, when you do the strength training, because of the lactic acid and the bit of extra carbon dioxide, you get lovely big veins, and then you don't have all that cycle. This is just a kind of aside. So it's about just doing something. So again, I'm going to do some. I can't do. If you can stand, please stand with me. We're going to do sit to stand exercise. This is a way of testing how fit someone is. I've got wheels on my chair, so I'm just doing this carefully. It's how many of these sit to stand. So it's like doing a squat. How many of these can you do in 1 minute? And it's building up your thighs and it's making you strong, but it's also giving you muscles so that if you are in hospital, for example, you've got a source of amino acids, protein broken down to amino acids to make antibodies. So we're going to stop there because I forgot to count a minute. But that's it. Thank you very much. So that's a way of testing how fit someone is. How many of those can you do in a minute? And we should be telling people that are coming up to an operation, for example, to do that. And if you tell people to do it, then they come back the next week and go, actually, I can do 29 now, or something. People need a thing they can do. And the best benefits for exercise is moving from doing nothing to doing something. And I worked with a team that had done the This Girl Can program, and they worked out that the reason that women and girls weren't doing exercise, this is about 10 years ago, is because they kind of felt a bit ashamed about being a bit wobbly or being a bit sweaty, or they didn't have time to fit it in. They didn't think they ought to. Is that sort of what they looked like? It was the problem. So they did big ads of people being a bit wobbly, being a bit sweaty, having fun, kind of getting a bit wrong, not wearing the right kit, but actually getting out, getting your heart rate up and doing something, preferably with other people. Couch to 5K has been very effective because it gives you that starter and some ways of getting through, building it into a habit. And We Are Undefeatable is about, for people who've got disabilities, ensuring they can put some exercise into their week. And the benefit tails off at about an hour a day, probably 40 minutes a day is good, and it tails off a bit after that. And this is a graph showing that you think the relative risk on the y-axis going from 1 to 0.9 is a reduction down to 90%, so a 10% reduction in the risk of getting something like a stroke, and down to 0.8 is a 20% reduction. So these do, obviously, different studies look at it in slightly different ways, so the numbers aren't quite the same, but actually there aren't big drug companies funding these things, otherwise we'd have had, everyone would know it now. And there are quite a few of these kind of studies around. I've put the arrow on the x-axis at 150 minutes a week, so you can see what we were talking about of kind of moderate cycling or swimming or really brisk walking or jogging or something that gets you a bit out of breath. So you can see that. So, but just note the biggest impact is just doing something. So we need to encourage people that are doing nothing to just do something because it's so beneficial for health. And this is England. About a quarter of people do no exercise at all. They do less than 30 minutes in a week of getting their heart rate up. And those are the people who are suffering in general, and more likely to have medical and health problems. So that's kind of the big win, to try and get people to do something. And there's a group that doesn't do quite enough, and then it's supposed to be 63.4% of the population do 150 minutes. But my hunch is actually that's including quite a lot of things that aren't perhaps as intense as maybe they should be. But anyway, we start at quite a low base. There's quite a lot to win. And it isn't just the doing exercise, it's also the not being sedentary. Sedentary is quite bad. And it's not just building up your heart and lung fitness so that you can get through an anaesthetic, for example. Exercise has an effect on metabolism. So it helps with your blood sugar management, whether you're diabetic or not, it helps with that. It helps with inflammation, which is probably why it reduces the recurrence of cancer just a tiny bit. It's fantastic for mental health. It gives people something they can do and be proud of and get them out of things that are going on in their head. It's very good for strength. As I say, getting to the toilet makes you more likely to be able to live in your own home. and be a day case if you're popping into hospital for some treatment rather than being stuck on a ward. Good for your heart function. As I said before, it's a reserve of protein. The muscles are where your body stores protein. So it's good for wound healing, antibodies, and it's really good for pain management. So this is Chris Whitty's report, the Chief Medical Officer in November 2023. I'm from Eastbourne, which is the little bobble on the right with the arrow. And you can see that in 2043, 25% of our population is going to be aged 75 or over. So we can't afford for 75-year-olds to carry on behaving like 75-year-olds do right now. We need to get them up and shaking it all about a bit and going and volunteering in schools and going for a little jog and demanding pavements are fixed and just generally getting up and doing stuff. As I realise I'm speaking to people that actually get out and do stuff, but I'm just saying people need to do stuff. And at the moment, I think people are fearful. And actually, Chris Whitty pointed out that older adults are scared of walking because the pavements are so dreadful. But being physically active is very good for mental health and physical health. And so it's not just me saying it, it's him. And there is something about being in green, they call it, green space and blue space. Being near water or greenery actually has an additional beneficial effect. That's from the Lancet. So yeah, I always tell people go for a walk with Granny, and it's actually much cheaper than going out for a meal. But we need people to do the working together, and I think there's a huge space for people to feel connected. That's another thing that's very good for mental health and actually physical health. And I think we need older people to allow young people to put their lives into perspective, because it's really, really difficult being a young person at the moment. So how does change happen? Basically, people need the why and the how. So it's different for individuals and for institutions or governments and stuff. Institutions and governments just need to know it'll save money. But for individuals, they need data, they need stories to why, they need the numbers, they need a reason. And the how, I've put that picture of cleaning up after your dog. So I used to walk to school in the 1970s or something. I'm a lot older than I look, just saying. And there was dog poo everywhere. And people, I don't know if anyone had a pooper scooper, but that's a pooper scooper. Can you see they've got it's like a little plastic trowel. And the reason no one picked up their dog poo is, what do you do with the pooper scooper? Like, do you scrape it off? Do you put it in your handbag? Do you wrap it in a plastic bag? Do you put it through the wash? No one knew what to do with it. And therefore they said they did it, but actually they didn't. So it's the practicalities. That's what people need to change. They need to know how to change. So, for example, I've got waterproof trousers in my panniers. So I cycled to work this morning. I hadn't bothered to check it was going to rain on the way home. I put my waterproof trousers over the top, cycle home. So it's just, you need the practicalities. You need that sort of thing available. So yeah, data and stories for individuals. People need to fit it into their schedule. It needs to be normal for their culture. We need to get their friends and families to, as I say, take Granny for a walk, run up and down stairs a few times, that sort of thing needs to be normalized. So this is the Orthopedic Surgeon's Guide to Brain Chemistry. So there are 4 happy chemicals. And we've all heard of dopamine. That's the reason you kind of play on your phone to see if someone loves you on Twitter, or people try and do gambling or whatever to get the hit. The dopamine's the hit. But we don't think about the other things. So serotonin you get from being included in a group. So if you've got it right now because you're part of this group, and you get it from sunshine. And so if you sign up for a charity walk or run, you're far more likely to do it because you won't want to let the group down. And actually 8% of UK adults are on serotonin uptake reinhibitors, which is an antidepressant. Serotonin is that important. And it's kind of missing in people, if you see what I mean. Oxytocin you get from doing a good deed. So actually, if you donate to charity or if you go and support a good cause, you get something back for your mental health and physical health from doing that, on top of the people of the organization you're helping. And endorphins take 20 minutes to work, and you get those from exercise, comedy, that kind of thing. So I always recommend to, I sit in fracture clinic, and people have punched walls because they're angry. And I tell them, you've got to have your running shoes by the front door to get out, to get your boost. It's the natural body's heroin, but you won't do it if it's wet and raining and whatever. But if you've got your walking shoes, running shoes by the front door, you can just go, and then you're not stuck in this moment, and you get your hit of endorphin in 20 minutes. Do you see what? So it's how we see health and everything together. This is Park Run. Park Run is now Park Walk as well, and is the Royal College of General Practitioners are linking with it to try, because it's so good for people to do that stuff together. 9 o'clock. There's 800 sites around the UK on a Saturday morning, and that was the A&E department at Eastbourne Hospital. Because nice team. I'm the one taking the photo, which is that was a long time ago. And then we've got a little bit of problem, because the best way to fit it into the your activity is to fit it in as just something you do, for example, cycling to work. And so I put this slide in. It's not all about cycling, but 62% of UK adults say it's too dangerous to cycle on the roads. But we need something for those journeys between 1.5 and 5 miles. Eastbourne's only 4 miles across, and yet most journeys are done by car. And if we could just convert those, as happens in the Netherlands or Cambridge or something, we would have a healthier population and fewer collisions and so forth. And generous parking quadruples the odds of driving a car to work. And actually, people who take the bus or public transport get a huge benefit for their health. It's about half the amount you get from walking, cycling, jogging to work. And 31% of older people limit their walking because they're worried about falls. It's not just me saying this. This is World Health Organization. They said, what are those things? We talked about nutrition and exercise. You can call it diet and physical activity, but it's these things. It's fitting it into the community. Labeling stairs. Stairs are really good for building strength and aerobic exercise. This is a 2019 Chief Medical Officer's Guide for all adults, and I've put up the infographic for disabled adults because this 150 minutes a week also applies to them, and it's more difficult to get it. So my top tip is find a swimming pool or something you can do that you can get that 21 minutes a day. It makes such a difference, and the strength and balance. And for frail older adults, they suggest in the Chief Medical Officer's Guide, stair climbing, short walks, break up the sitting down time. And this is from the British Medical Association. I wasn't involved in this one. Healthy transport means healthy lives, because it's also less pollution and better for people. And this is, sorry, there's another one about cycling. In the Netherlands, people aged 80 are far more likely to cycle than people aged 30 in England and Wales. And we're only 250 miles apart. We're the same species. It's what we consider as normal is very different. This is just a picture of some lovely electric bikes, 2 electric bikes, and basically you take the battery out, and the right-hand picture is you just plug the battery in once a week. And people who electric bikes are amazing. I now have 3. Because it means you don't wonder whether you'll go out in the car or a bike. You just take the bike, because if it's going up a hill, you just press the button a little bit more. You still get just the same amount of physical activity as people on a normal bike during the week, because you go out for so many extra journeys just because it's so easy. You need a big strong lock though, and that was Salisbury is loaning their staff electric bikes, and they've had a fantastic result from that. And the NHS should be rolling this out. I have discussions with the active travel team and the green NHS team, because it's ridiculous that the staff are so unfit and miserable, and we need all sorts of things to improve secure cycle parking and lockers and so forth, because the benefits to health actually outweigh the risk by 10 to 1. Bit about pollution. It's not just the petrol fumes. It's also the fine particulate pollution from tyre and brake wear, and that goes on the weight of the car. So if anyone has bought an electric car, that's fantastic. You're not polluting everybody with the petrol diesel fumes. But those tiny little particulates get into your lungs, they go between the cells, they bypass the immune function, and they could cause problems. So it's not just lung function and asthma, it's type 2 diabetes, dementia, heart attacks. Heart attacks go up massively with pollution. And that's from Royal College of Physicians and Royal College of Paediatric and Child Health. And then another chief medical report. I do like my chief medical officer reports. This is me in the BMJ about if road traffic collisions were a cancer, there'd be the 5th leading cancer in the UK, and we just normalise having over 1,000 people die on the roads every year. It's just it is, a lot of it's preventable, and it's ridiculous the way the money goes. The box is about, I've helped with petitions try and get a crossing outside a school, and it joins the list of another 79, and they've only got funding for 3, and there's councils going bankrupt. So the money is slightly in the wrong place. And in Edinburgh, when they changed to 20-mile-an-hour limits, they reduced their road traffic casualties, that's particularly pedestrians, by 40%. And we need to think the UK population, 20% are children, 52% are women, 18% are over 65, and that's going up rapidly, as I mentioned. 25% of the adults have long-term conditions, 62% of working age population are parents, and they're trying to do the school run, they're trying to take kids to rugby, they're trying to balance their day, and yet we have this norm of the heroic person going to earn money and actually a lot of people are balancing a lot of other things, and we need to value part-time working, we need to value carers, we need to respect people for every hour they are in work, and try and make it easier for them to achieve that. And that's a nice picture I took when I was in the Netherlands, of a car on a roof. I was trying to say it's poor parking provision actually is, you make it difficult and people are more likely to take the bus or cycle. And yeah, 20 is plenty is quite a good movement actually, because it's obviously the kinetic energy transfer when you hit somebody at 30 miles an hour means they're far more likely to have major injuries. I've been fixing people sitting in fracture clinics for 25 years, and I'm tired of this, and it is improvable and it really damages lives. So there's a difference between 20-mile-an-hour limits that are cheap. You can put them up as just signs at the entry points to where people are, or a town. 20-mile-an-hour zones are a different thing. That's when you have to put chicanes and build outs and stuff to try and make it difficult for drivers to drive more than 20. And that costs, thousands of pounds, putting in all these extra speed humps that actually are quite annoying. And actually, once people have learned to drive at 30, they do it. My mother's in London, a lot of places in London. So like you drive, you sit behind someone and you think, yeah, actually, you don't want to overtake the cyclist. You allow people to cross the road. You see people stepping out in front of you that no way would they do that in Eastbourne or Worthing or somewhere. So yeah, everyone needs to do something. So Swim England, this is the hyperlink to the fact sheets. I was on their health commission for 7 years, and we wrote 20 fact sheets about how to swim with epilepsy, how to swim with dementia, how to swim with diabetes, all these things, not really to tell people how to swim, because to be honest, you get in the water and slosh around a bit, but it's also just to make people realize that what's the worst that can happen? The worst that can happen is you have a seizure in the water, but if you have a seizure in the water, all that needs to happen is someone holds your head out of the water. You don't have to get the whole body out. You don't have to call an ambulance. So it's the kind of, what's the worst scenario? And once you know that, you're kind of confident in the rest. But it was also trying to train this swimming pool staff that if someone says, oh, I've got asthma, allowed to swim, they don't go, oh, I'm not sure. You have to come back on Tuesday when the boss is in. They go, oh, wait a minute, I'm sure we've got a leaflet for somewhere. Let me find you a leaflet. So it's a positive, So yeah, find your exercise. Movingmedicine.ac.uk is a fantastic website that, again, I help with faculty of sport and exercise medicine. It's got lovely videos. It's about the numbers, the data, the stories, and the how to get people started. And then how do we fix the NHS? Because actually we can reduce the number of people with these conditions. We can reduce how severe each condition is just a little bit. And it doesn't always work. Some people are unlucky. But actually it's also 10%, 10 to 15% of operations have a complication. They're 5 times more likely if someone's frail, 4 times more likely if someone's physically inactive. And if people can do an exercise program before their operation, they reduce their complications by between 30 and 80%. And those are the links for the evidence. And the Centre for Preoperative Care has got that. And we've worked with Macmillan on an exercise program for people not just having surgery but having cancer treatment, and it's really empowering for them and enables them to maintain their independence for much longer and deal with the complications of chemotherapy and so forth. We've got some new stuff on the Centre for Preoperative Care website about the 7 things that can reduce complications. Just the top few reduce complications by 50%. Smoking cessation, exercise, nutrition's only about 40%. That's fruit, vegetables and protein, essentially. Getting medications sorted. There's far too many people on multiple medications that actually are doing them harm. 10% of admissions to hospital have some cause of poor medication management leading up to their admission. Alcohol moderation is very important because obviously your liver has to process the anesthetic, and if it's too good at processing alcohol, you need more anesthetic, and people are more likely to fall over if they and dips if your body's used to it. And mental preparedness and practical preparedness, and it might make people day caseable if they do some of this, so they're fitter and they're practically prepared to go home. Then you haven't got so many hospital beds, you aren't having to put agency staff, you haven't got people in beds falling over because they're disorientated or catching bugs off other people. And day case is amazing. In fact, we've got a webinar I'm doing next Tuesday with our new day case delivery pack about how to, I'm going to say, pack people into day case much better because it's much more efficient. Everyone knows what happens next. You're not waiting to be told, and you don't have to go up and down in lifts and stuff. So this is the answer to the NHS waiting list. And the next thing is about shared decision making. Because talking about that high complication rate, particularly in people who are frail, we need to have some proper grown-up discussions about should we be operating at all in some places. There's a regret rate of 14%. 4% of people regret the operation they've had. It's only 3% for hip replacements that are absolutely amazing. And it's about 30% for some cosmetic procedures. But so it's kind of, should we be doing something for this individual patient? And people are so different. There are some people that think, oh, actually, I'm 90, I don't want to have such and such operation. You think, fair play, we might make you worse. What's the do nothing option? What will happen? Well, this might grow or it might not grow, or whatever it is. We need to have those grown-up conversations, the benefits risk alternative, and not treating, doing nothing, the BRAN. But we don't need anyone having those conversations. They need to be a doctor or a geriatrician or a GP or a surgeon. And then on to sustainability. Sustainability is reduce, reuse, recycle. And if we're not doing operations or not having complications and admitting people to intensive care and stuff, or we've got shorter stays, less ill health, that's fantastic. But no one measures that. It's like, oh, today is the day I should have got dementia, but I didn't get it because I've been swimming 3 times a week. No one says that. Do you know what I mean? It's kind of, we just don't realise how well we're trying to do each. We're so, and it's not measured, and there people don't prove it's valuable. So this is a picture of my hip, and I know you're not orthopedic surgeons, but you can imagine that's not a ball in a socket. So it was very painful and difficult twisting because it's supposed to be a ball in a socket, but I could move it up and down. So I could get out of my bike. So I got fit. I went out on my bike every day, electric bike, up to Beachy Head and back in Eastbourne. It's beautiful, beautiful. There's me having my operation, and then I was a bit wobbly afterwards, so I got one of those static things. But I think anyone going up for an operation should go on the neighbourhood WhatsApp group and go, anyone got one of those static exercise bike things you put in your front room? And then someone goes, oh yeah, I'll deliver it round. I'm not using it. It's in my garage. And then you do that every day, 21 minutes. And then you're much better for your operation. I went home the next day. And we need to do that. But it shouldn't be about me. It should be, how can we get people to do a little bit, just a little bit better, so they get home a day earlier, 2 days earlier, so they have fewer complications. So it's like, why do we do something to support other people to be physically active? Because it's not about you. it's about other people. And it's nice because we're nice people. We want to improve their mental health. We want to make them happy. We want them to have physical, but actually, seriously, we can't afford not to. This would save NHS costs, save social care costs. Each of us is predicted to need 10 years of social care. There's at least 6 million carers in the UK. Lots of people drop paid work to be carers. I, in fact, started being part-time in 2015 when my mother got dementia and I'm her deputy under the Court of Protection, and I couldn't deal with solicitors and bailiffs, sadly, and house clearance and putting in new bathrooms and caring, all that stuff around a full-time job. And yeah, and it's better. So onto social care. This was a paper I wrote in 2017 about if we can focus on physical activity, we can help avoid unnecessary social care. So there's whole commissions on how we can afford social care. I know I'm tired and I'm bigging myself up, but actually this is still the only thing I've seen about how we can prevent the need for social care. Because actually aging is different from lack of fitness. It is not normal to age 90 not be able to walk up a flight of stairs. You need to keep on using your legs to walk up the flight of stairs and to walk and to build your muscles. People who start exercising can improve their fitness to the level of someone 10 years younger. And that does reduce the need for social care. People can get to the toilet in time, just need someone to pop in twice a day, maybe to check they've done their shopping and made their bed and do a bit of cleaning or whatever. They don't need live-in care. And this is from East Sussex County Council, the revenue budget. The purple bit is adult social care. So this is costing huge amounts of money, and councils are going bankrupt. They're not allowed to go bankrupt. They're doing I can't remember what it is, Section 112 or something that's like going bankrupt. They've run out of money. They're even shutting the toilets in Eastbourne because they haven't got enough money. We can't afford it. We can't afford the increasing numbers of people. And this is about to cost more than the NHS. And the other thing to say is about 27% of people in employment in East Sussex are working for local government or education or health or social care. So that's an awful lot of people who are doing amazing, really busy, hard, difficult works, and they deserve it and they're earning money. But actually, a lot of them are doing things that if we change the way we did society and environments, would be work that wouldn't need to be done. All those people processing blue badge, and all that processing of stuff, all the pharmacy technicians. It's just mind-boggling once you think about how much time and energy and people's effort goes into, how much of the workforce goes into managing this. And this is a slide, just to kind of put it in a picture term, that if you can maintain, and I appreciate some people can't, and some people have disabilities that don't allow them to, but if you can maintain that strength into older age, you're far more likely to have a nice old age with not very much ill health and then die at the time you would have died, if you see what I mean, rather than hopping over that disability independence threshold. So we fixed the NHS and social care, now the economy. So this, again, I like pictures, but this is a graph with the single grey blob is 1% of patients. And 3% of the patients are responsible for, this is the area of the curve, is the amount of money that a hospital spends. 3% of patients are responsible for 45% of the costs of a hospital. This is acute hospitals. And those are the people that have multiple complications, readmissions, unexpected intensive care stays. So that's why it's worth tackling the people that currently need more help. And there's an awful lot of people at the bottom having a day case procedure very cheaply, if you see what I mean. And actually, there's now an additional 400,000 people unable to work due to ill health since the pandemic. So we've actually got much worse levels of ill health in the UK. And just to talk about the number of working age people per person age 65 or above, At the moment, it's about 3.0, 3.1 in the UK of people between the age of 16 and 65. We can't, the number of people over 65 is going up massively. So we can't afford to use up too many of the working age people looking after the older people, if you see what I mean. Now, in Japan, they've got a different ratio. They've got even fewer people of working age. And what they've it's 2 to 1. What they've done is encourage people to go out and have social connections, and for the older people to do half an hour of exercise. They call it the locomotive syndrome, half an hour of exercise every day to try and keep them as healthy as possible, to stop them needing care. This is quite a sad graph. This is from if you live in the most deprived 10% of areas. Oh, sorry, I've gone backwards. You not only do you die sooner, but you live twice as long in ill health. So it's just a different way of looking at it. 26 years in poorer health. So we need to improve that. And this is about the pavements. 31% of people say and the pavements are cracked partly because of heavy vehicles going over them, but it does make a huge difference to people wanting to get out and do something, and walking is the entry level of doing something, really. And 10% of operations are cancelled roughly due to bed shortages for some of the complex cases, including shortage of intensive care beds, and quite a few readmissions preventable. And then we can talk about prevention. People talk about prevention, but they think it's something you do for the future. Oh, I'll go get a bit fit now so I'm better in 20 years' time. And actually, it works quicker than that. And primary prevention is never getting something. You could also say it's reducing the risk of getting something, because you might still get it anyway. You know, we all know somebody who smoked 20 a day and lived till they were 100, but actually it's about doing your best and trying to reduce the risk. Secondary prevention is something like catching it early and having an easier treatment, like screening for something that you can have an easier treatment, like cervical screening. You can have a smaller operation and prevent it spreading. A tertiary prevention is something you don't really talk about. It's when you've already got the condition, doing something to reduce your risk of having a complication of the condition. And that's, I think, where we need to aim, because this is where it's the teachable moment where we've got the biggest wins. So if someone's about to have an operation, they've just got a new diagnosis, they've had a health scare, we can get them then and try and get them to do those 7 things to improve their health. That is more likely to work as that teachable moment. Just one slide on obesity. Again, it's very related to social deprivation. You can see this is in 5s rather than 20s. We can talk about before, but you're twice as likely to be living with obesity if you're in the most deprived area than the least deprived area. I'm on the Obesity Health Alliance, and they've produced quite a lot of reports about trying to prevent it, and we need to do something about marketing and ultra processed food, but it's different. What works to treat it is different. So this is a slightly complex slide, but I put it in because I just want to kind of say exercise doesn't fit obesity. Exercise is very helpful for creating new habits. And actually, probably part of the obesity epidemic, I'm going to say, is caused by carbohydrates. Carbohydrates are not necessary for part of a human diet. They're all converted to sugar. You eat bread, it goes sweet in your mouth. They then gets converted to fat. You get a surge of insulin that causes the storage, and then you feel hungry 2-3 hours later, and so you eat more. So it's really difficult to stick to a low calorie diet. And actually, we probably demonize fat too much. And there's some good data about low carbohydrate diets and intermittent fasting. Both of those 2 separate things do actually help to reverse type 2 diabetes and obesity. But we're working on some stuff for that. And actually, the Eat Well guide from, as was Public Health England, from suggests you should have 35% of your calories from carbohydrates. Is actually probably making people worse. It puts up people's HbA1c, which is a measure, if anyone has diabetes, it's a measure of that. And actually, if you add in the it's this needs a radical rethink. And there are other people saying this as well. It's not me being a weirdo. Okay, on to perioperative care. This is from the moment surgery is contemplated in full recovery. And you can imagine all those different steps when you have an operation. But the problem is people work in silos and they don't talk to each other. And lots of things are duplicated, or something doesn't happen because someone else should have done it, but they didn't do it and they didn't realize how important it was to another part of the chain, as it were. And what we're trying to do with the Centre for Preoperative Care is to get everyone talking to each other and to streamline the pathways and to accept if someone's done an assessment, we've got the same information we can carry forward, and people know what other people in the chain are, what they need to see. So this is from, you can see all these major royal colleges are involved on the board, the Centre for Preoperative Care. And it's been lovely. I've been working there for 5 years now. One afternoon a week it's supposed to be, but I was shielding during the pandemic, so I did about 3 days a week. We've written reports and all sorts of things. We've got lots of people on lots of charities on our advisory group, which is really good, because then we put out messages. We're not saying we shouldn't operate on people because we're trying to ration care, which is what the government's doing, and then everyone argues against it. We're saying we shouldn't operate on this individual person here because we've talked to them about what the operation might involve and what the complications might be like, and they've taken the sensible grown-up decision that they don't want to go through with that. Then that's a positive, because they're creating their own health for how they want to be. So it's working with patients and charities. And I think I've covered most of this already, but 47% of the operations done in England that require an anaesthetist, not the local anaesthetic, cataracts and things, are in older people who have these, many, as I say, have multiple morbidities and complexity and are more likely to have complications. And I think I've covered, this is just different people like pictures. They're the pictures. We've covered this already. And we've now got these infographics about stopping smoking, and the craving lasts 90 seconds, and the horrible withdrawal symptoms start going down after 2 weeks. But you need a plan for when you get when you might be triggered. It's things like that. We've got something on exercise, as I say, moving medicine. If you Google moving medicine, it's fantastic. And some people have formal prehabilitation programs, but other hospitals can't afford it. So people need to do something. And in fact, I've just persuaded the Friends of Eastbourne Hospital to buy 60 copies of the book, The Power of Preparing for Surgery. And we're going to have a photo shoot next week of handing it over to the chief executive of the Friends of Eastbourne Hospital. I'm one of the book authors. And we're going to have a library system to lend them to patients, but critically to lend them to staff, so that they can quote them to the patients. When the patients say, oh, I'm not sure if I'm allowed to go for a walk because I've got diabetes, I might hurt my feet. They go, no, it says here, just have good shoes and go. You know what I mean? It's trying to, and we talked about this, and this is my mother going for a walk. She's 89, she's got dementia, and she's doing great. And this is trying to get more geriatrician involvement. So geriatricians are doctors who are specialising in older people's health, and people who have been intended for an operation, who have a consultation with a geriatrician. 14% decide against surgery. And that's quite a lot. It's often the people that would have had complications, quite serious complications, but they actually get better because they've been given all this improved medications, and some of their medications stop, for example. So perioperative care is better. It's better for patients, better for costs, better for staff. And it's just crazy. The Royal College of Anaesthetists has spent over £1 million over the last 5 years, and yet no one's heard of it. And it's trying to get the patient better, but also trying to get team working better. I wrote this when I was on the Council of the Royal College of Surgeons of England, avoiding unconscious bias. And it's not really, you can't avoid unconscious bias. You look at someone, you form a judgment. That's how our brains work. But what we need to do is train ourselves not to go, oh, you're a bit short to be a surgeon or whatever, but to go, if you're not sure if someone's young, you don't say you the junior doctor, you say, are you the registrar? Or, you don't say, I don't know, there's kind of a way of lifting people up a little bit. If you get that kind of, oh my word, they shouldn't be in this position, the police officers look too young these days kind of thing. It's lifting people up and having an expectation based on what their job role is rather than what they look like. Because we get it wrong. This is loads of things on sexism, racism within the NHS and within surgical, within the BMA, or, you know, it's just everywhere because people haven't been taught how to behave and not to just pretend they're treating someone with respect to their name badge expect. And the problem is it does affect how patient care is delivered, because if someone's rude, for example, the witnesses decrease their willingness to help others, and they kind of shut down a bit, and therefore they're not helping with something else that might make the operation or the endoscopy or whatever it is go a bit better. So we need to stop people. Dr. Chris Turner's done a huge amount of work. He's amazing on this. And again, the Association of Anaesthetists has got ways of stopping people being idiots and rude in the operating theatre. That I notice your stress. Is there anything the team can do to help? And there's something about having a sort of a moment, because some people are going through all of this. I put this up while I have a slurp of food, of drink. Because we're dealing with a workforce. We need to look after them. You can't expect people to be perfect. You can expect them to be good enough. You've got that standard. And I think people are so busy thinking they've got to be perfect that they don't realize sometimes just turning up to work is a bonus. And if somebody is lashing out at someone or being rude, the first thing to ask is, are you okay? And we've got some things about behaviour. So it's not all the disciplinary march to HR, because that takes forever. And I'm sorry if people have had to go through this sort of thing, but people collect their evidence and try and explain they weren't being rude. It wasn't what they intended, whatever. It's really, that's sure needed for criminal kind of behaviours. But actually some people need that cup of coffee with a shut door, but it's a cup of coffee. It's a Vanderbilt cup of coffee where you say, some of our colleagues were upset with how you behaved. It's actually being clear. And it does, the Royal Australian College of Surgeons found it did stop poor behaviour in some colleagues. Just a few words. So I'm going to run slightly over time, talking about women doctors. There is a problem that the people in charge always write the rules. This isn't just about women doctors, but it's about life. The people in charge write the rules, and they're the ones who got there, but we don't think about the people who failed. Now, I manage, just between ourselves, because I can survive on very little sleep. And during the 1990s, as a registrar, you would operate. If there was any operations to be done, you would do them. But it's not compatible with having a life. But I had no plan B. I wanted to be a surgeon. That's what I did. But now all training posts are 48 hours a week, and you can work less than full time in any of them you can request to. And now we've got problems with childcare and people not getting paid enough and spending all their time doing paperwork. But actually, things are different now. Some women have always made it. And now only 21.1% of licensed doctors are white men. These are figures from the GMC. And you can see the women and men on the two bars on the left. We're at 49%, 49.9% women doctors with a license to practice. We've got a press release ready to go from the Medical Women's Federation and the GMC. It'll be about December or January when it tips. And we need to expect that women will be doctors and women will be good doctors, and they do things in a different way, and actually they have better results, possibly because the patients have unconscious bias and they think they're nice. And my clinic's always overrun. I don't operate on people that have changed their mind and were too embarrassed to come and ask, as some of my colleagues might. And there are lots of barriers. It's not just the motherhood. It's people not realizing what people have had to do to get there. And there's a kind of macho ideal about how you will be. And sometimes you've got to have dips. And we've got to talk about pregnancy and breastfeeding. This is a breast pump. And if people take a year off work to breastfeed on demand, which is great if that's what you want to do, I'd have gone absolutely stir crazy. This is, you can express milk, so your breasts aren't too uncomfortable. You can take it home in a freezer bag, put it in the freezer in the hospital, take it home for daddy or the nanny or the whatever to feed the baby, or throw it away. And most babies will mix and match bottle and whatever if they're hungry. And I think the thing is, two opposite things are true in general. Women and men are different. Women in general are more likely to be calm, and men are more likely to want to do the macho thing. And then that's probably because society's set up that way. And women are more likely to go part-time, for example. But any individual shouldn't have those assumptions lumped on them. They should be allowed to do whatever they kind of have the inclination, the skills, whatever to do. And we need to lift people up who've had a slightly worse experience in the past, so we get them through this horrible phase so they can be good for the end of it. 91% of women doctors report sexism. And unless we get the women in the middle management roles, and we need more role shares and secretarial support and that kind of thing, particularly in the NHS, then there's no one to apply to the top level jobs. No one, I'm going to say normal. I'm not normal. I'm a really bad role model. So it's the equality. People are too busy trying to pretend they haven't noticed the difference. And actually, what we need to do is notice the difference, embrace the difference, diversity in your team. If someone's on your team, not in front of other people, maybe ask them what they need to be the best they can be. And maybe there might be 1 or 2 days they have to get to work a bit later because of this, give them a bit of flexibility, but it gets them through that phase so they can be amazing afterwards, and promote them in case they're a bit scared of things. I mentioned the Royal Australian College of Surgeons. They've done amazing stuff about respect. I've mentioned the Kennedy report about microaggressions within surgery and people treated differently. There's a gender pay gap even though we've got the same contract, we earn whatever, 24% less. Only half of that is explained by maternity leaves. This is a personal slide I've put in because my husband left 2 years ago, which I found absolutely shocking. I thought we were a team together, but it's really difficult and something that 42% of couples go through before the 20th wedding anniversary. And it's been an interesting phase, but people need to nurture their relationships and also acknowledge there are different phases of life, and sometimes you probably grow out of each other. And I didn't realize that's what had happened to him. He didn't explain it, and he left, and now it's taken me and also that you get through stuff. It's taken me 2 years of feeling very miserable to realize actually I've got whatever 10, 20, 30 years to do my thing now. And we need to be honester about that, I think, and not just see the marriage thing as the only ideal. Going to slip through some other things. We need to. This is the paperwork with one admission, and we need to shrink that down. And the computers make it worse because it's all hidden. And we actually need to standardize things a bit more so that the administrative staff can help with collecting data so that the clinical staff can get on and do that critical decision-making thing. And this is just about the pay scales, which I'm trying to get doctors' assistants who are people who can help doctors. And we won an award for them. And I'm trying to get it rolled out as a national thing, that the people who've been healthcare assistants for a year that can help put in drips, take blood, get the blood results on top on the ward round, just generally speed things up and be useful and helpful and improve patient care, and keep the doctors from resigning. Because everyone should be like a Formula One team, but it doesn't need to be the fancy Formula One team. It just needs to be a standard kind of setup. That's the garage in Eastbourne. They're great. And as I mentioned, I've gone through cancer treatment. I had a stem cell transplant, but I was told I wasn't eligible because my heart wasn't good enough, because the cancer had affected that. So I got an electric cycle, and that's one reason I'm so passionate about it, that I had to prove that I was fit enough to be allowed to have the stem cell transplant, which I had in 2020. No one noticed because there was a pandemic going on. So I had the harvest, did a bit of shielding, went in September, and I went back to work. And I'm doing great. Thank you very much. So I'm trying to always persuade people not to scare people who are having their first wobbly cycle ride. And that means drivers need to hang back and not overtake if it's not safe. These are pedestrian casualties in Eastbourne. We're trying to improve those. And we would do that with 20 mile an hour. We really, really would. That's 142 people, pedestrians. So it's everything, isn't it? Sustainability, everything. So that's my last slide. And there's some QR codes on BMJ articles and things. And we need to just value each person for the moment they're there, because that might be really important. But we also need to standardize how we manage things, life courses and pathways of care. So I'm going to stop sharing. Thank you very much for your attention.
Wow, Scarlett, thank you so much. If you'd asked me this morning when I saw your list of slides what chance you had of getting through them, I wouldn't have given you more than about 5%. And so, I mean, you've done an amazing job, but you've given us so much to think about. And I'm not going to waste time here with my questions, because I'm sure there's lots of people on this call who have got questions that are burning. And so who would like the floor? Yeah, Janet.
Hi. Gosh, I've written so many notes, but in this time, I have to say, I have booked 2 swimming lessons. I decided, yes, I've got to go swimming, so I've booked 2 swimming lessons while you were talking. And I thought, I need to get a bike. I haven't, the first time I went on the bike was when Soroptimist went to Munster, and I hadn't been on a bike for 30 years. And I'm scared of the cycle of a bike, but I'm now going to get myself a bike and go around the little flat bit nearby near the centre. But also, one thing you said was the plate needs rethinking. And I think the plate that you showed was something that we show our children. Why did you think the plate needed rethinking?
Sorry, the what needs rethinking?
You said a plate. There was a plate of
It's the
food.
Eat
You
Well
Yes,
guide. Yeah.
thank
said that
you.
needs rethinking.
Yes, because the human body needs protein and fruit and vegetables for the minerals and vitamins. But the question is, do we need carbohydrates? Because when you eat carbohydrate, we all know sugar's a bit bad for you, but when you eat pasta, potatoes, bread, it is converted, that's long chain carbohydrates. They get broken down into sugars. And so when you
Mhm.
eat it, and very quickly it gets converted to sugar, even in, as I said, with your bread, even in your mouth with the amylase. If you practice, try it later, it gets sweet. And that gets, you get a big sugar rush, and your body produces insulin to store the stuff. And it stores it in glycogen in your muscle. We can only store 400 grams of carbohydrates. And then once that's full, it stores it as fat. And it's very, very easy to convert carbohydrates into fat. And the other thing with the insulin is then it dips and then you feel hungry again later. So it's really hard to stick to um, a low calorie and low energy diet if you're also eating carbohydrates. And the other thing is your body is either storing or using energy. And if you're on a high carbohydrate diet, the 34% or whatever, then you can't burn your fat because your body wants to burn the sugar. It's expecting sugar. It wants to burn sugar. So it's very difficult to lose weight again. So actually, eating fat doesn't necessarily make you fat. We've demonized it too much. And eating fat, eating protein makes you feel full. And then you don't want to eat again for ages. Or fiber is also useful for that. So there's some evidence that people who switch to a low carbohydrate diet reverse their type 2 diabetes. And it actually, we've just written something we're going to publish at some point. As in, we haven't done the research, but we collated all research that it happens so fast that people are on lots of tablets for their diabetes or for their high blood pressure need to be aware that they shouldn't take quite so many of those tablets because they're likely to have, they don't want to fall over because their blood sugar or blood pressure goes down. So yeah, low carb. If you look up low carb, look up Freshwell, and I wrote a BMJ article on obesity. But yeah, we'll have another one coming out at some point. But yeah, it's actually, I genuinely think we've messed up because as a surgeon, I keep getting emails saying your patient's due for surgery in 2 weeks with diabetes. And I know they're diabetic, have diabetes. They get their HbA1c, which is a measure of how your diabetic control's been over the last 3 months. Their HbA1c is whatever number it is. Do you want to operate? And as a surgeon, I think, yeah, of course I want to operate. They've got a problem. I want to operate. I want to help. I want to make them better. But the other thing is I know when they go off to have more tablets, more insulin, more of the eat well plate, it doesn't get their HbA1c down.
Is that then a focus for you to change this plate, which is kind of what I would show my families.
Yes. So it's difficult. So as I say, I think it's called Freshwell. There's a fairly new organisation called the British Society for Lifestyle Medicine, and they've written quite a lot of stuff about this. Um, there's a Freshwell, I think, is there's one you pay for and there's one you don't pay for. And yeah, and if or there's a book by Dr. Malhotra called The POP Diet. Tom Watson, who was deputy leader of the Labour Party about 10 years ago, wrote something about downsizing. I think he called it a book. So, it's proven, it's out there. It's kind of the 1950s diet, but we've messed up.
Hey, Helen, thank you for that, Scarlett. I'm sure it's something that some of us will want to be in contact with government about, because I mean that debate has been going on for rather too long, and it does need to change. Helen.
Mine wasn't another question. It was also, should we not, still sticking with the diet and what children and adults, should we not also be thinking about the intermittent fasting and talking to adults and children about finishing eating earlier in the evening?
Yes, that's a very good point. And also not grazing the whole time.
Yeah.
But yes, we should. But I can't do everything all at once, so I'm leaving that for.
No, I appreciate that. I only said it because Janet was asking, and Janet is in direct contact with children, so she can say it to her kids.
Yeah, I mean, with kids, I mean, if people are running around doing exercise, they do need the fuel.
Yeah, yes,
and for that, maybe carbs is okay. But yeah.
Okay.
Thank you.
Every question inevitably raises more questions and needs for action. I'll just take one more question, and then I think we must let Scarlett go. Has anyone got a burning question that they would like to ask while they've got the opportunity? Put your hand up now. Well, I can't see any. Yeah, Nikki.
So firstly, I just want to say thank you so much for that. I consider myself quite fit and healthy, but even so, I know I need to push it up a level having listened to you. And thank you for your honesty as well. I just wanted to ask what your thoughts were, given the fact that I may be reading, and it may not be correct, the various weight loss jabs that are now available. And I understand the National Health might be providing this to certain patients, and I just wanted your thoughts on that.
Thank you. They do work. They work by suppressing appetite. There are some downsides of them, and they're hugely expensive. And what do you do when people have finished, the course? The problem for me is actually. And we're just writing something from the Centre for Preoperative Care about, because they delay stomach emptying, and some people have stomach contents from a week earlier, and then if they have an anaesthetic, that can be a problem, because you have an anaesthetic that goes starved from midnight, but actually they've still got stomach contents if they're on these things, so that can be dangerous if that then gets inhaled. So they do work, but it's the whole package, and what else? What do you do afterwards? And bearing in mind the low carbohydrate diets are so incredibly effective and cheap, and don't have these side effects. I'm quite keen to get some of the knowledge about that out, so people do that, because it's horrible if you are overweight trying to stick to a diet. Lots of people have done it on and off for years, and it doesn't really work. But actually, there are some things that do work, and the low carbohydrate diet works because you don't feel so hungry. Yeah, that's not a good answer, but there we go.
Are you quite the fact that the National Health is providing this for some patients? And some patients might see this as an easy
Patients need
option.
it. patients need it,
Okay.
absolutely, and it works for them and it transforms their lives. Absolutely. I'm not knocking that at all. But in terms of trying to do it for the whole country, it's not going to work with, prevalence of in some areas 30% of obesity. It isn't going to work. And it doesn't, what we need to focus on prevention and reducing ultra processed food and all that stuff. But in terms of treatment, I think we should be putting effort into getting the low carbohydrate diets, and knowledge about that, and more fruit, vegetables and protein, and not eating quite so often, and all that stuff out into the media, rather, because people seize upon the exciting new drugs. The other thing that works is bariatric surgery. That does work, but then it stops people later absorbing vitamin B12. But it doesn't necessarily work because of the physical stomach changing sides. It probably works because of the impact on the hormone, how the hormones work around the stomach.
Thank you.
Yeah, that's just fantastic, Scarlett. And I'm not going to spend another 5 minutes saying thank you, because there's lots of messages in the chat, all of them saying thank you so much for sharing an amazing amount of material with us. And it gives us lots of food for thought and lots of opportunities to build on what you've said and think about how we can use that material more in the sort of campaigning work that we do, but also in our own everyday lives. So thank you very much indeed.
My pleasure. I've just put a link in the chat for a thing about low carb. It was a throwaway line and something I wrote earlier. And I'll put one more link in the chat, but I'll disappear now. Thank you very much for your attention. It's been lovely talking to you, and keep up your work. And it's all those little bits add together make such a difference to everyone else. So thank you.
Thank you for your time. Good night.
Bye.
Yeah. Right.
Barbara, I have to say, was that a pun? I don't know if you realised that's giving us food for thought.